Assalamu alaikum. Good evening, everyone.
Good evening, Dr. Helmy. How are you?
I'm fine.
Okay, that's great.
Welcome,
I
everyone.
guess the students are joining the session. So once they join, we can start in 2 to 3 minutes. Is it fine for you?
Yes, sure, no problem. Okay, let's
Thank
wait.
you. I guess all the students have joined us. So let's get started with today's session. Please let me know in the chat box if I am loud and clear to all of you. Hi, Dr. Aisha. Hi, Dr. Dina. Hi, Dr. Anisa. Hope all you are doing well. And I welcome you all in today's webinar, in which we are going to discuss about the most important topics of MICOG, that is the postpartum hemorrhage, that will be conducted by our expert mentor, Dr. Muhammad Helmy. But before starting the topic, I'm going to give you the overview about a regular course for MICOG 1 so that you know when you have to join the course and what you will be getting out of this course. So let's get started. So first, meet our amazing team of mentors. We have Dr. Muhammad Helmy, we have Dr. Jazri, who you all are familiar with. You know about how these amazing mentors teach you, their teaching styles, and these will be the mentors who will be guiding you in your MICOG 1 pathway, and they will be the one that will lead you to the success of MICOG 1. So let me tell you about the features that we are offering in our MICOG 1 premium course. So the first feature that I'm going to talk about is the live sessions. The live sessions, you know all about it. These are the most important module that we are giving you. In these live sessions, we are going to cover each and every important module that is necessary for your MICOG 1 preparation. In the live sessions, we are going to cover all the important topics. Then, whenever there is a live session on the very next day, we are going to provide you the recording of all the live sessions. So in case you missed any live session, you will get the recording of that. And also, we're going to provide you the PDFs of all the important modules. So in case you want to do the last minute revision, you will get the PDFs. So apart from the live sessions, we are going to provide you the topic test that will help you to assess your preparation, and we're going to provide you the mini mocks so that your preparation will be top notch. And then, apart from the live sessions, we are going to provide you the important exam revision questions that contain all the important questions that you will be needing for your MICOG 1 preparation. And apart from that, when you will join the course, you will be added into the study group where all the mentors will be added, and you can post your queries over there. They will be there for your guidance. And then we're going to give you the biostatistics workshop that will be held by our amazing mentor, Dr. Jazri, who is going to make this a piece of cake for all of you. So in the end, we're going to provide you the mock exam that will be just like your real exam so that you can have an essence of your MICOG 1 exam, what it will be before your actual exam. So now let's talk about your study plan, what you will be getting in the regular course. So once you will join the regular course, you will be in the pre-course phase. And what is that? So pre-course phase is basically when we are going to provide you some recorded sessions along with the PDFs and a study plan so that your basic knowledge would be good. So once your basic knowledge will be good, then you will be shifted to the live session phase that is starting from 15th of August. And in the live session phase, we are going to thoroughly discuss about each and every topic with the help of the expert mentors. And then there comes the phase 3, which is the revision phase. So after all your concepts are clear in the pre-course phase and the live session phase, then all the revision will be done in the revision phase for your best preparation. So now let's talk about all the phases and the details so that you know what you will be getting after you join our MICOG 1 course. So in the phase 1, in the pre-course phase, we are going to provide you the course schedule for the pre-course activities that will contain all the recorded lectures, all the PDFs. You will be added into the study room, and you will be getting the mini mocks. So all these will help you to build your basic concepts. So once basic concepts are done, you will be added into the live session phase, in which we are going to conduct the live sessions to clear out all your queries, to clear out all your concepts in the live sessions with the expert mentors. And then In the end, we will be having a revision phase in which we are going to revise all the important topics that you have covered in the pre-course phase and live session phase. So trust me, with the pre-course activity, with live session phase, with the revision phase, I can guarantee you this thing that you can clear your exam. So we have been conducting this MICOG1 course for 7 years, and we have reached 96 to 98% success rate with the help of the amazing mentors that have been guiding us and leading these courses for MICOG1 and guiding all the students out there. You can check our reviews from our page as well. And if you are thinking of, starting your MICOG1 journey, then this is the solution. You can join the course and ace your MICOG1 exam. And also, just to support all the doctors out there, we are giving the special gift for all the webinar attendees who are attending us today. We are going to give you 40% off on our MICOG1 courses. And for this, we have our course manager, Fatima, who is going to help you get the discount. So we have shared our numbers in the chat box. Contact us for details. So Dr. Helmy, over to you. You can continue with your topic. Thank you.
Thank you so much, Fatma, for this nice overview about our course. And in a while, we are going to start the main topic of our webinar today, which is the postpartum hemorrhage strategies for effective intervention and care. This is our main topic today. Of course, the management of postpartum hemorrhage is one of the important topics and important basics any obstetrician should know, because in our practice, we face a lot of cases of postpartum hemorrhage and we should know how to deal with them. And of course, this is an important topic also for the exam for the three parts of MRCOG, part one, part two, and also part three. So today, inshallah, we are going to summarize the Green Top guideline about postpartum hemorrhage in a way which suits part one MRCOG. So let's start talking about our topic now. And of course, when we talk about the types of postpartum hemorrhage, we have two types. We all know that. We have the primary postpartum hemorrhage, which means the loss of 500 milliliters or more of blood within 24 hours of the birth of a baby. And this will be the main scope or the main topic of our session today, how to deal with the primary postpartum hemorrhage. And the secondary postpartum hemorrhage, which means a bleeding from or abnormal bleeding from the birth tract or the birth canal between 24 days and 12 weeks postnatally. And usually the secondary postpartum hemorrhage is due to maybe infection or retained products of conception. So when you deal with the secondary postpartum hemorrhage, we usually deal with the cause directly. But in primary postpartum hemorrhage, we know that the most common cause is the uterine atony. So we need to have a stepwise management strategy how to deal with such cases. So let's start talking about the primary postpartum hemorrhage. And when we talk about the degrees of postpartum hemorrhage, we have minor degree of bleeding from the birth canal, which is about 500 to 500 milliliters to 1 liter, and the major one, which is more than 1 liter. And we can classify the major or subclassify the major into two categories, the moderate and the severe. The moderate is between 1 liter and 2 liters, and the severe is more than 2 liters. So this is the classification, but we should put in our mind that not all the cases respond to blood loss in a similar way. So some females or some patients may withstand or can, deal, or we can see that they can withstand the loss of blood, unlike some other women. For example, those who have lower body mass index, they may suffer a clinical shock quickly than other women. So we need to not only depend on the amount of blood, but we have to focus on the clinical symptoms and signs. And of course, the postpartum hemorrhage is or primary postpartum hemorrhage is the most common form of major obstetric hemorrhage. It's one, of course, of the major obstetric emergencies that we need to deal with in a stepwise way. So, what are the risk factors and causes of postpartum hemorrhage? We usually classify them, into the 4 T's, okay? The tone, thrombin, tissue, trauma, okay? The 4-letter T, okay? So we have any causes or risk factor which can affect the tone of the uterus, okay? Like the multiple pregnancy, the patient has a history of a previous postpartum hemorrhage, okay, fetal macrosomia, anything which can cause uterine overdistension might affect the tone of the uterus. Also, things that can affect the coagulation profile, like a patient is having a preeclampsia and she got HELP syndrome, for example. So this affect the coagulation profile of the patient. It might be something related to the tissue or the placenta, like retained placenta, or morbidly adherent placenta, like placenta accreta, for example. Also, it might be due to trauma. And this is the traumatic postpartum hemorrhage, like perineal laceration, or the patient had episiotomy, okay, which might be extended and deep episiotomy, okay. I might request you all to make sure that you turn off your mic, please. Okay, thank you. So these are the main risk factors. And if we have a focused look on the causes, like for example, if we talk about abnormalities in the uterine contraction, most of them are due to over distension of the uterus, like a patient is pregnant with multiple pregnancy, or she had a polyhydramnios or macrosomia, or might be, a functional or anatomic problem of the uterus, okay? Or the patient had uterine relaxants like magnesium sulfate, or might have like beta 2 agonist, like she got a tocolytic agent before she got in labor, for example, bladder distension, and also the distension of the rectum, that this might cause what we know as uterine inertia, and this cause normality in the contraction of the uterus. Also, the retained products of conception, like I told you that the patient might had like a part of the placenta retained. For example, if she had a placental anomaly, okay, like a pilopate placenta, or a subcentriate loop of the placenta which remain inside the uterus, or it was a morbidly adherent placenta. So this might also cause postpartum hemorrhage. The trauma to the genital tract, like lacerations to the cervix, to the vagina, to the perineum, and this even might be extended. So in vaginal delivery, we might have cervical lacerations, which even may extend to the lower uterine segment, or the reverse. We, in some cases, like when we do a cesarean section, we might have extended laceration from the lower uterine segment to the cervix and to the upper part of the vagina, or a uterine rupture case, or also a uterine inversion. So if you made a rapid traction on the placenta, it might cause uterine inversion, and this can lead to postpartum hemorrhage. Am I audible, everyone? Because some candidates are complaining of the voice. Okay, very good. Also, causes that affect the coagulation profile, like if the patient is having a pre-existing bleeding disorder, like the von Willebrand disease, the most common inherited bleeding disorder. She had hemophilia, immune thrombocytopenic purpura, or something acquired in pregnancy, like the gestational thrombocytopenia. But this, is a very uncommon that it cause, a clinical effect. Preeclampsia, which is complicated by HELP syndrome, or the patient had disseminated intravascular coagulation due to like amniotic fluid embolism, placental abruption. All these causes can cause DIC, affecting the coagulation profile, leading to postpartum hemorrhage. So to reach the cause of postpartum hemorrhage. So if you have, a patient delivering vaginally or by cesarean section, and now she's suffering postpartum hemorrhage, you need to make a careful examination to the patient to determine the cause of postpartum hemorrhage. So generally, we need to exclude that the patient is having a medical problem like coagulopathy, or she is having a traumatic postpartum hemorrhage. And of course, to exclude that there is no retained products of placenta or conception. So after excluding all these causes, it will be the atonic postpartum hemorrhage, which is the most common cause of primary postpartum hemorrhage. So the most common cause of primary postpartum hemorrhage is uterine atony. And this is, of course, an exam question, can come as a single best answer question asking you what is the most common cause of postpartum hemorrhage. Of course, it will be uterine atony. So how to minimize the risk? How to minimize the risk of postpartum hemorrhage? First of all, the patient should be screened for anemia, okay? And if she is proven to have anemia, she should be treated by iron supplementation, whether oral or parenteral iron supplementation. So we need to screen the patient by doing a full blood count and check the hemoglobin level. And of course, we need to remember that the hemoglobin level is different according to the trimester. So the lower limit of normal hemoglobin level in the first trimester is 11. And from the second and third trimester, it's 10.5. So if the patient is having lower hemoglobin level than the normal, she should screen for the cause of anemia. And we know that the most common, of course, is iron deficiency anemia. But of course, we need to make sure that it's iron deficiency anemia first, and then give the patient iron supplementation, whether oral or parenteral, if the patient is not responding well to the oral supplementation, or if we are approaching the labor and we need a rapid correction of hemoglobin, we might consider giving her parenteral iron therapy. So this is the first thing we should consider to minimize the risk of postpartum hemorrhage. Second thing is to try to reduce the blood loss at delivery. But we need to make sure or to remember that uterine massage, to do a prophylactic uterine massage, this is of no benefit in the prophylaxis of postpartum hemorrhage. This is of no benefit in the prophylaxis of postpartum hemorrhage. So you don't do it as a routine for every case having delivery, okay, that you do uterine wrapping or uterine massage. This is not recommended as a routine for prophylaxis against postpartum hemorrhage. Of course, it will be considered in the management if we have already an established case of postpartum hemorrhage, then of course we need to do this massage, okay? But as a prophylaxis, it's not of any benefit. So the most important to reduce the blood loss at delivery is the prophylactic uterotonics. The prophylactic uterotonics. They should be routinely offered in the management of the third stage of labor. And this we call as the active management of the third stage of labor, to give a prophylactic uterotonics. So what are the important ecopolics or uterotonics we might give for a patient in the third stage of labor to minimize the risk of postpartum hemorrhage? If the patient is delivering vaginally, okay, we should give her oxytocin 10 international units by direct intramuscular injection. And this is the agent of choice for prophylaxis in the third stage of labor. So this is another exam question. What is the agent of choice in the active management of the third stage of labor? Of course, it will be the oxytocin. This should be given with the birth of the anterior shoulder of the baby, or immediately after the birth of the baby, before the cord is clamped and cut. So it's better to give it once the anterior shoulder is seen at the introitus or at the vulva, okay, then start giving the oxytocin. Or immediately after the birth before you cut the cord. If you are delivering the patient by cesarean section, then you can give the oxytocin 5 international units by slow intravenous injection. So this is regarding the oxytocin in the patient delivering vaginally and by cesarean section. Also, we might consider giving a combination of preventive measures, like the centometrin, which is a combination between the ergometrin and oxytocin, okay? This should be given in patients to minimize the risk of the postpartum hemorrhage, but we should make sure that the patient is not hypertensive because ergometrin can cause a high or shooting in the blood pressure. So if a patient is hypertensive, ergometrin will be avoided or contraindicated. Also, in a woman who is at increased risk of hemorrhage, we might consider giving the tranexamic acid, intravenous tranexamic acid, in addition to the oxytocin. So a patient who have minimal risk of postpartum hemorrhage, you can give oxytocin alone. A patient who is at increased risk of hemorrhage, then you can consider a combination therapy between ergometrin and oxytocin, but make sure that the patient is not hypertensive. And also you can add intravenous tranexamic acid. Are the prostaglandins necessary in the prophylaxis for postpartum hemorrhage? No. According to the Green Top guideline, the prostaglandins will not add any more benefit than the conventional injectable uterotonics like the oxytocin and or the ergometrin. So we don't give prostaglandins as a routine prophylaxis. We have the carbetocin also, which is something like the oxytocin, but it's a long-acting form of it. We can give the carbetocin in an IV bolus, and this can be used in preventing the postpartum hemorrhage in elective cesarean deliveries. So quickly again, if we have a patient who is having a very low risk of postpartum hemorrhage, then we can give oxytocin alone. If you are giving that for a vaginal delivery, then it will be 10 units intramuscular, cesarean delivery, 5 units intravenously. If a woman is at high risk, give a combination and add also the tranexamic acid. No need to give prostaglandins as a prophylaxis, and we can also consider the carpetocin in some cases delivering by cesarean section. So am I clear so far, everyone? Okay, very good. So how to assess the severity of bleeding? Of course, the most important is to depend on the clinical symptoms and signs. As you know, we know in the pregnancy, as a physiological change in pregnancy, there is increase in the circulating blood volume. So the signs of hypovolemic shock might be, variable among the patients. So we need to make sure that we estimate the amount of blood loss very well, the visual estimation of the amount of blood loss, and also to add the clinical signs and symptoms together. So if the blood loss is less than 1,000 milliliter, usually we still have the patient vital signs in the normal range, like with the blood pressure are usually maintained in the normal range. If the blood loss is between 1 and 1.5 liters, then the patient might start having tachycardia, tachypnea, and the systolic blood pressure might start to fall a little bit. But if the blood loss is more than 1.5 liters, then we might observe altered mental state, worsening tachycardia and tachypnea, and we might have a systolic blood pressure below 80 millimeter mercury. So this is the symptoms and signs according to the amount of blood loss. And even in the guidelines, they mentioned that if you have patient whose blood loss is more than 1.5 liters, the consultant on call should attend in person not only notified by the telephone or so. No, the consultant should attend in person, because now this is a critical case which need, the most senior staff to deal with. Also, there is something called the shock index. The shock index is an equation between the heart rate and systolic blood pressure. It's usually, calculated in the non-pregnant women, which is the heart rate divided by the systolic blood pressure. And this has been employed as a marker of hemodynamic compromise. So the shock index can identify the woman at risk of adverse outcomes secondary to postpartum hemorrhage, like admission to an intensive care unit. So this shock index can be compared to the conventional vital signs. So if you know the shock index of the woman before she got pregnant, you know her average heart rate and blood pressure, and you have her shock index, this might give you an idea about the vulnerability of this patient to have signs of shock and complications secondary to postpartum hemorrhage or not. Now let's talk about how to deal with an established case of postpartum hemorrhage. The management is started by a proper communication. And this communication should be with the patient and her relatives, and also with your team. So first, of course, and if this is the patient is having, a good mental state, she's not in, coma, or she's not in altered mental state, you can, of course, describe to her what's going on, and there is bleeding, and we are going to deal with that. And also, it's better to, communicate with her birthing partner, like her husband or whoever was attending with her. So this is important to describe to the patient what's going on, and that we are dealing with the situation. Also, you have to consider the relevant stuff at the appropriate level, and good experience according to the type of postpartum hemorrhage. I mean that if you have a case of minor postpartum hemorrhage without clinical shock, then the midwife in charge and the first line obstetrician and first line anesthetic staff can deal with the case. But if you have a major or ongoing postpartum hemorrhage, and there are signs of clinical shock, then you have to notify, or the senior obstetrician, senior midwife, senior anesthetic staff should deal with the case with notifying the consultant obstetrician on call. And also, as I told you, if the bleeding is more than 1.5 liters, he should attend in person. You have to alert the hematologist, alert the transfusion lab, and also you have to ask one of your team members to just record everything happening in the situation, like to record the amount of blood, what are the drugs given, what are the management strategies have been done, who are attending and when they attended. Everything in the situation should be documented and recorded, and this should be done by one of the team members. So then we have to focus on how to resuscitate the patient, how to restore the blood volume. So I classified them, like, instead of talking about the the assessment alone and the intervention alone, I'm going to talk about the assessment and intervention at the same time about each type of postpartum hemorrhage. So when we talk about the minor postpartum hemorrhage without clinical shock, all you have to do is to take 20 milliliter of blood from the patient for group and screen, full blood count, and coagulation profile, including measuring the fibrinogen level. And you have to record the vital signs, the pulse, the respiratory rate, the blood pressure every 15 minutes. So this is the assessment needed in cases of minor postpartum hemorrhage without clinical shock. And you have to put one cannula, one intravenous access, 14 gauge cannula, and you can start warm crystalloid infusion. In such situation, as mentioned, this is a minor bleeding, and if it's controlled like that without clinical shock, it's okay. But of course, if the bleeding is ongoing or major or starting the clinical signs and symptoms of shock, then we have to deal with the situation in another way. So if now we have a major postpartum hemorrhage and the bleeding is ongoing or there are signs of clinical shock, then we have to do the ABC strategy for resuscitating the patient. We have to assess the airway, the breathing, the circulation. We have to consider putting an oxygen mask, okay, even or regardless of the maternal oxygen concentration. Then, so you have to give her 10 to 15 liters per minute of oxygen, regardless the maternal oxygen concentration, and assessing the circulation by putting two 14-gauge cannula or the orange cannula. So we have here in the major postpartum hemorrhage, we have two axes or two intravenous cannulas, not only one. And then you take also a venipuncture, 20 milliliter of blood for cross-matching, 4 units at minimum of blood, and doing a full blood count, coagulation screening, and this also will include fibrinogen, but make sure that you can or you may need to repeat the test from time to time, usually every 30 minutes or every 1 hour, okay? Because if there is ongoing bleeding, okay, you have to repeat measuring the coagulation profile because this will guide you uh, 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 in the matter of the blood product transfusion, if you need to give more blood, more plasma, and so on. And also you have to measure the baseline renal and liver function test. You have to monitor the temperature every 15 minutes. So this is the vital sign which will be measured every 15 minutes, but the other vital signs like the pulse, blood pressure, and the respiratory rate will be continuously measured by oximeter, ECG, and automated blood pressure recording. So the vital signs will be continuously monitored, except the temperature you can measure every 15 minutes. And of course, you have to insert a Foley's catheter to measure the urine output. So these are the assessment and investigations regarding the major postpartum hemorrhage. Regarding the intervention, as I told you, for the airway and circulation, you have to give oxygen and to give two or make two IV axes, two 14-gauge cannulas, and you start fluid therapy. And the maximum will be 3.5 liters of clear fluids. We can divide them into 2 liters of crystalloids and 1.5 liters of colloids. Of course, we are going to consider blood products transfusion, and this will be discussed in details in the upcoming slides. We might give also tranexamic acid by IV injection, and of course, keep the patient warm. You have to maintain the patient temperature. All the vital signs and everything should be recorded in the modified early obstetric warning score, and you have to document everything going in dealing with such case. We might consider arterial line monitoring if there is an experienced staff available for that, and we can consider transferring the patient into intensive therapy unit or monitoring the patient at high dependency unit. So this is how to deal with the major postpartum hemorrhage or patients having ongoing hemorrhage or signs of clinical shock. So am I clear so far, everyone?
What about a massage of the uterus, sir? Compression of the uterus.
Yes. I'm going to talk about the interventions we are going to do. I'm just talking about the, the first thing in resuscitating the patient. We are now resuscitating the patient, okay, and recording the vital signs and everything about the patient. But of course, we are going to mention now the stepwise management, okay? This is all about resuscitating the patient and how to restore the blood volume. So what are the blood products we use? The blood products we usually use, of course, we can give the cross-matched blood. Of course, it's very important when you give a blood to the patient, it should be cross-matched, and it should be ABO, RH, and K antibodies, K also, or K antigen, I mean, compatible. Okay, so this is to avoid alloimmunization. And if the cross-matched blood is still unavailable, you can give uncross-matched group specific, like if the patient, for example, is A positive, then you have to give her A positive blood without, you know, checking the other antigens like K and the K kill antigens and the C antigens and so on. Okay, so at least give her the same blood group. If not the same blood group available, you can give her O negative blood until her specific group is available. So the first priority for us is to give a compatible red cell or red blood cells. Like it should be ABO, RH, and kill antigens compatible red cell units. If cross-matched blood is unavailable, you can give uncross-matched group specific, like the same group, A positive, P negative, so P negative, AB positive, so I'm going to give here AP positive, okay, without searching for other antigens. If not, then we have to give her O negative and K negative blood until switching to group-specific red cells as soon as feasible. In elective transfusion, if the patient is not in an emergency, we should consider giving the patient cytomegalovirus seronegative products to avoid transmission of the cytomegalovirus to the baby. But in urgent transfusion, if the patient is in a clinical shock and we need emergency transfusion, then we can, avoid such, condition. Like we can give her blood product without screening for the cytomegalovirus. Why? Because most of the blood banks in the UK are what we call leukocyte depleted, means that they remove the leukocytes from the blood, so this already minimize the rate of transfusion or the transmission of the cytomegalovirus from the blood to the patient. So if the patient is in an emergency situation, then give the blood without screening for cytomegalovirus. But if in elective transfusion and I have the time, so we can search for a cytomegalovirus seronegative products. Also, there is one of the strategies which might be considered, which is called the intraoperative cell salvage. Means that the blood emerging or lost from the patient is collected, filtered, and retransfused to the patient once again. This is can be considered if it's feasible in the center dealing with such case. Okay, so this is about the blood. What about the plasma? Of course, we should.
Sorry, can I have a question? Sorry about the simple questions. But what do you mean by K negative blood? It's first time to heard about it. Can you just hear what the type of this type of blood? K negative?
Yes, that's another antigen, okay? Like the D antigen of RH, we have C antigen, we have E antigen, we have the kill antigen or the K antigen. These are all antigens found in our body, okay, in the blood, okay? And the K antigen is one of the antigens which cause, if you like, for example, if a patient is not having the antigen, like she is K negative and she received the K positive blood, this can cause severe immunization, okay? and a lot of antibodies will be formed against this key antigen. Okay, so if the patient once again receive a K positive blood, this can cause severe hemolysis and hemolytic anemia. So this is another antigen like the Rh. It should be compatible when you give the patient a blood product, okay?
Okay, thank you so much for clarity.
You're welcome. So, of course, the fresh frozen plasma transfusion should be guided by the hemostatic results. I mean, the coagulation profile. But if there are no hemostatic results available in when you deal with the patient, and there is severe bleeding, and you still don't have the results of the coagulation profile, then you should start giving fresh frozen plasma, and the first unit of plasma should be started after the first 4 units of RBCs. So if you finish giving the patient 4 units of RBCs and you still don't have hemostatic results, then start infusion of the first unit of plasma in a dose of 12 to 15 milliliter per kg. So how many units of blood and how many units of plasma to give to the patient? We have 2 strategies, a 6:4 RBC fresh frozen plasma ratio. So for each unit of so for each 6 units of RBCs, you can give 4 units of plasma, or you can give by another strategy is 1:1. Like if I give 4 units of RBCs, I can give 4 units of plasma. So this strategy or this strategy can be applied. After that, you should have the result of the clotting test, and you should maintain the PT and activated partial thromboplastin time. So you have to maintain the PT and APTT, okay, to be less than 1.5 the normal. Okay, so this is the cutoff value. We need to maintain the PT and the activated partial thromboplastin time below to be 1.5 the normal to become below, I mean 1.5 the normal value. So this is the guide of infusion of fresh frozen plasma. Of course, if you are giving fresh frozen plasma or a cryoprecipitate, which contains factor concentrate, I mean, this better to be as the same group of the recipient. But if unavailable, fresh frozen plasma of a different blood group is acceptable, providing that it doesn't have a high titer of the anti-A antibodies or anti-B antibodies. And also, no anti-D prophylaxis is required if an Rh negative woman receives Rh positive plasma or cryoprecipitate. So if we don't have the same group of cryoprecipitate or plasma, we can give another group, but make sure that they don't have a high titers of antibody, which can cause hemolysis of the patient's blood. The next blood product we might use is the cryoprecipitate, which is important to maintain the level of fibrinogen more than 2 grams per liter. If the fibrinogen level is low, this can cause more bleeding. So we give cryoprecipitate to maintain the level of fibrinogen more than 2 grams per liter. The platelets also should be given if the platelet count is less than 75 by 10 power 9. So if the platelet level is less than 75, you have to give platelets to maintain the level more than 50, at least to be more than 50. Of course, if it's more than 75, it will be better. And also the platelets should be blood group compatible. So if you give a platelets of different blood group, especially if the patient is Rh negative, and you give her platelets from an Rh positive blood, then you have to give anti-D immunoglobulins. Regarding the recombinant factor 7, it's used in some trials to manage the bleeding of postpartum hemorrhage, but it's not recommended routinely unless this is a part of a clinical trial. But it is used in some cases, life-threatening cases, and I have seen cases in my practice, they responded well to factor 7, especially if they have major bleeding that is complicated by disseminated intravascular coagulopathy or DIC. And when they were given recombinant factor 7, the patient condition improved well. So it might be used in life-threatening conditions. So our main therapeutic goals, and this is very important, to maintain the hemoglobin level more than 8 grams per deciliter, to maintain the platelet count more than 50, and of course, it's better to maintain it more than 75, but you start the transfusion when the platelet is below 75 as a safety margin. Prothrombin should be less than 1.5 the normal, and the same for the activated partial thromboplastin time, and the fibrinogen should be more than 2 grams per liter. So these are the therapeutic goals when we give blood products. Clear so far, everyone?
Yes, it's clear, but I have another questions. My question is, when we give fresh frozen plasma or blood to the patient, when can I know when to stop giving her the pints of blood or plasma? Should I continue to give the patient plasma or blood until the bleeding stops? So can I give her a limited pint of blood and plasma? I just want to clear this. Or I just have to continue to give her blood and plasma until I reach this readings in this slide, for example, hemoglobin more than 8, or I just want to know when
Simply,
to stop giving her the plasma and blood.
you will
Okay.
simply you will not reach these goals if there is a continuous bleeding. Like if you have a
Yes.
bag and you pour water in this bag and it's open from below, all this
It,
water will continue to
yeah,
be lost. So you will not reach
yeah,
this goal unless you stop the bleeding. So it's a combination of both strategies. Okay, you give as long as the bleeding continues, and you repeat the test, okay, from time to time until you find that the bleeding stopped and you reach the goals. For example, you might stop the bleeding, but you still didn't reach the goal. Okay, so the patient, for example, lost like 3 liters of her blood, and hemoglobin level is now 5 or 6. Okay, but the bleeding stopped. Are you going to leave the patient? No, you have to continue giving her the blood until the blood become, or the hemoglobin become more than 8. Okay, so it's a combination policy. Okay, clear?
so I can
Clear
reach
or not?
unlimited so I can reach unlimited pints of plasma or blood. For example, 10 pints or 15 pints. It's okay.
Yes, yes. We saw
Okay.
patient talk like
Because I
40.
didn't saw a patient of PPH before, so I just in my practice, so I ask that.
You are so lucky.
Okay. Okay, thank you so much.
You're welcome. Okay, so these are the therapeutic goals. Now let's talk about how to arrest the bleeding. Of course, if we have a cause of bleeding, like as I told you, if we have retained products of conception, like retained placenta, you have to remove the placenta. The bleeding will not stop unless you remove the placenta. Okay. If you have trauma, you have to deal with the trauma. Like if you have a perineal laceration, cervical laceration, whatever, you have to deal with the trauma. Also, if the patient is having coagulopathy or medical disorder, you have to correct the medical disorder and this coagulopathy by the blood products. The problem is that when the uterus is not contracting, the problem is in the tone of the uterus. This is the most common cause, and this is what you know is we have to go through in a stepwise way to make sure that we use all the strategies for making the uterus to contract, and as much as we can without delaying, and this is important, to avoid hysterectomy, but without delay, because sometimes if you hesitate in taking the decision of hysterectomy for the patient, you might lose the patient. Okay, like We have a statement here. We always say that a living woman without a uterus is much better than a dead woman with a uterus. Okay, so you have to, yes, try to make strategies to avoid making hysterectomy, but also avoid the delay in the decision, because you might lose the life of your patient. So we have a combination of mechanical, pharmacological, surgical methods, and we should use that in a stepwise way. Regarding the mechanical, sorry for that, the mechanical methods, of course, it's the massage of the uterus. We have to rub the fundus of the uterus and also ensure that the bladder is empty with a Foley's catheter, and usually it's left in place to make sure that the bladder is empty. And also, if you suspect that the patient has a full rectum, and this is usually not common because the patient usually before delivery, she empty her rectum and so on. But if you suspect that, of course, you make sure also that the rectum is empty, but it's important, of course, that the bladder become empty with a Foley's catheter left in place and the massage of the uterus. And this is the mechanical method we have. Of course, we usually don't do a mechanical method alone. Of course, we are going to use that with the pharmacological methods. And the pharmacological methods, as shown in this slide, are giving oxytocin 5 units by slow IV injection, like the cesarean section prophylaxis, and we can repeat the dose. We can also give ergometrin, slow IV or IM injection, but this is contraindicated in hypertensive women. Or we can give the oxytocin in an infusion way, like we give 40 units in 500 milliliter of isotonic crystalloid at a rate of 125 milliliter per hour. Okay, but of course, if the patient has any problem, needs fluid restriction, so this infusion will not be a good method. So you have to give the oxytocin directly. But if there is no fluid restriction, then you can give oxytocin infusion. The carboprost, which is a prostaglandin F2 alpha, can be given by intramuscular injection, and sometimes in cesarean section, it can be given directly intramyometrial. So this carboprost is a prostaglandin F2 alpha, and this is also an exam question. They ask you about the nature of carboprost. You give 250 microgram by intramuscular injection, and you can repeat that in every 15 minutes, but the maximum is 8 doses. The maximum are 8 doses or 2 grams, and also the prostaglandin F2 alpha can trigger asthma, so it should be given in a caution or with caution in patients suffering bronchial asthma. The misoprostol or prostaglandin E1, also in the exam, you can be asked what is the type of misoprostol. It's a prostaglandin E1 analog. It can be given sublingually, and this is the recommended route. It's another exam question. What is the recommended route of misoprostol? You can give that sublingually. Of course, in the management of postpartum hemorrhage, you will not be given anything vaginal because this will be pushed away by the blood. So you are going to give the misoprostol in the sublingual or by the sublingual way. But you have to consider or put in your mind that the misoprostol has a delayed effect. It takes 1 to 2.5 hours to make the uterus contract or to increase the tone of the uterus. So these are the pharmacological agents you can use. Of course, if the bleeding stopped by the pharmacological and mechanical strategies, we are lucky, and the condition now is stable, and we can transfer her to a high dependence unit for monitoring. But the problem is if the bleeding continues. So after giving the pharmacological agents, especially if you give carboprost and still there is a tonic hemorrhage continues after the 3rd dose of carboprost, okay, so or if this happens like 30 minutes or more after the first dose was given, the team now should consider transferring to the patient to the operating theater to make a laparotomy and we like doing now surgical management of the patient. So carboprost, we know the maximum are 8 doses, but we will not wait until the 8 doses finished. If after the 3rd dose or after 30 minutes of the 1st dose, we still have atony, this means that the pharmacological agents most probably will not be effective, and we might consider doing laparotomy and surgical intervention for the patient, or at least start the surgical intervention, which is the first line, the intrauterine balloon tamponade. So the surgical methods we have are the uterine balloon tamponade, the intrauterine balloon, laparotomy and doing uterine compression sutures. We call them the brace sutures. And even it's recommended that we have in the theater a diagram showing the way how to make the brace suture, how to take the sutures and compressing the anterior uterine wall and the posterior uterine wall and so on, because there are many brace sutures techniques. Okay, for part 1, of course, it's not important to know the techniques now, but at least there will be a laminated diagram at the theater to guide you how to take these sutures. The third line, to do a stepwise devascularization of the uterus until ligating the internal iliac artery, or to make selective arterial occlusion or embolization by interventional radiology if of course it's feasible and available, if there is failed internal iliac artery ligation. And the last resort will be doing hysterectomy with preservation of both ovaries. You have to leave the ovaries, of course, to avoid the menopausal symptoms for the woman. And if you are going to make a hysterectomy, it's better to have a second experienced clinician with you. A second consultant will take the decision with you. Okay, 2 persons should take the decision with each other. So these are the surgical methods. When we talk about the intrauterine balloon tamponade, it's inflating the balloon of Sangstaken blackboard tube or a Foley's catheter, whatever the type of the balloon you are going to use. This is the first line surgical intervention. And this is a very important exam question, by the way. It's repeated a lot in the MRCG Part 1 exams. What is the first line surgical intervention in management of primary postpartum hemorrhage? You are going to answer it's the intrauterine balloon tamponade. Usually, if it's going to be effective in 4 to 6 hours, the tamponade should be adequate to achieve hemostasis. Of course, if it achieved hemostasis, you should remove it in the daytime hours, not at night, and when there is appropriate senior staff, because you might remove that and you might, surprise that there is more bleeding. So you have to remove it after notification of the senior staff in the daytime. Okay, so you have all the precautions in case there is more bleeding you can deal with. Also, before it's completely removed, you should deflate the balloon first and leave it in place to make sure that the bleeding does not recur or reoccur. We have what's called the tamponade test. The tamponade test means that if you put the balloon tamponade and the bleeding coming from the cervix now is becoming minimal or stopped, we call that positive test. And usually the tamponade will be effective and the surgical intervention or the laparotomy will be avoided. But if you put the tamponade and there is still ongoing bleeding from the cervix, this means that the test has failed and laparotomy will be performed. Of course, when you do the laparotomy, as I told you, the first line is to do the brace or the compression sutures for the uterus, or we call that the P-Lynch sutures or the brace sutures. The second is to do stepwise devascularization. So you can start ligating one uterine artery, then both uterine arteries, then you can ligate both uterine arteries, but at a lower level, near their origin from the anterior division of the internal iliac artery. Then you ligate one ovarian artery, then both ovarian arteries. If this is not effective in stopping the bleeding, then you will ligate both internal iliac arteries. Of course, we usually ligate the anterior division of the internal iliac artery, because that's the origin of the uterine artery. If the bleeding stopped and all the coagulopathy is corrected, don't forget about the thromboprophylaxis. It's not because the patient is having bleeding that it's not she is not subjected to thrombosis after that. Okay, so if the patient is having a high risk for developing thrombosis, or according to the scoring system of the thromboprophylaxis in pregnancy, this is another guideline, of course, you have to give thromboprophylaxis for the patient, but of course after you stop the bleeding and you make sure that all or the coagulopathy is corrected. If you are still, suspecting that the patient is not, fully controlled, then at least use these mechanical methods to prevent thrombosis, like the anti-embolism stockings, the foot impulse devices, the intermittent pneumatic compression devices. All of them can, decrease the risk of thrombosis formation if the chemical thromboprophylaxis is contraindicated, if the patient, for example, is having thrombocytopenia or so. So if you are not going to use chemical thromboprophylaxis like low molecular weight heparin, so at least use these mechanical methods to minimize the risk of DVT. So after management of the case, we mentioned also after all the surgical interventions, if they all failed, then you have to make hysterectomy to save the life of the patient. After dealing with the case, there are some points we have to put in our mind. The post-care of postpartum hemorrhage. Every maternity unit, as a risk management, should have a multidisciplinary protocol for the management of postpartum hemorrhage. Every unit should know how to deal with such a case, how to, communicate with the hematology lab, how to communicate with the senior staffs, how to communicate with the, hematologist to deal with the case. So we need strategy when we have a case, how to communicate with each other, how to make the blood available for the patient in a convenient time. So all of that should be written in a multidisciplinary protocol, and all the staff involved in the unit should have a training in dealing with postpartum hemorrhage. And those cases, of course, having postpartum hemorrhage more than 1.5 liters, they should have an incident review. Okay, they should have an incident report or an incident review. Also, everything happening in the situation, as I mentioned before, should be documented. All this stuff attending and the time they arrive, the sequence of events, what are the given pharmacological agents, the blood transfusion, the surgical intervention, the signs and the condition of the mother throughout the different steps, the timing of the fluid and blood products given. All things happening in the case should be documented. And the last thing is the debriefing. The debriefing is to talk to the woman after stabilizing her condition and her birthing partner at a convenient time, to tell her what happened and how was the situation and how we deal with the situation. This is called debriefing, and this is very important in the communication with the patient. Of course, you are going to be subjected to all these issues, especially in part 3, when you are talking to a patient or a role player, and you have some cases you need to make a debriefing to the patient. Of course, you are going to learn that in part 3, inshallah, soon. So this part, you are going to practice that physically with the role player. So regarding the secondary postpartum hemorrhage, quickly, of course, as I told you, secondary postpartum hemorrhage, usually it's due to infection or retained product of conception. So you have to do microbiology to take a high vaginal endocervical swab. You can do testing for endometritis, and the appropriate antibiotic should be started. Also, you should do a pelvic ultrasound to exclude the retained product of conception. and to do surgical evacuation by an experienced clinician. Uterotonics might be used, but their uses or the evidence of their use is limited. Like you can give misoprostol, ergometrin, might be beneficial in some cases. But as I told you, it's usually a problem of infection or a retained product. So the uterotonics, their use is limited, or the benefit of their use is limited. In some cases, we might need a balloon tamponade or transcatheter arterial embolization to stop the bleeding in cases with ongoing bleeding of secondary postpartum hemorrhage. As I told you, the problem with secondary postpartum hemorrhage is the infection. We have seen some cases, and their management is somehow difficult. So secondary postpartum hemorrhage is not a good a case to deal with, especially if the problem is infection. And I have seen one case, she had to do a hysterectomy because of secondary postpartum hemorrhage, because the uterus or the uterine tissue was so friable and infected. So she had to do hysterectomy to save her life. So to summarize our topic, and this, of course, algorithm is found in the Green Top Guideline. If you have a major obstetric hemorrhage, you have to call for help. This is important in any obstetric emergency, to have a supporting team with you. You have to alert the senior team, senior midwife, obstetrician, anesthetic staff, alert the hematologist, alert the blood transfusion lab, and the consultant on call should be notified or attend in person. As I told you, if the bleeding is more than 1.5 liter, and then you have to start the resuscitation of the patient, airway, breathing, circulation. You have to give the oxygen mask, fluids, blood products, and you have to make two IV access to the patient, like mentioned here, to have to do the full blood count, the coagulation test, and should be repeated. Continuous monitoring of the vital signs, and simultaneously, while you are resuscitating the patient and restoring the blood volume, you start the medical and mechanical management, like rubbing the uterus, giving the uterotonics as mentioned before. If there is no response to the pharmacological and mechanical strategies, then you have to consider the surgical intervention. The first will be the intrauterine balloon tamponade, or if not, then you have to do laparotomy, press sutures, stepwise devascularization, bilateral internal iliac artery ligation. We can consider interventional radiology if feasible. The hysterectomy is our last resort if there is no response to all the surgical measures, but a second experienced clinician should be deciding with you that decision. And of course, after stabilizing the patient, she should be transferred to a high dependency or an intensive care unit. So this is how to deal with the case, and how or what are the important points in our Green Top guidelines of dealing with postpartum hemorrhage. As I told you, it's a very important topic in our practice and also for the exam. I hope you enjoyed the discussion. And of course, if you have any question or any feedback, I will be happy to listen.
Thank you so much for this nice presentation. But unfortunately, we used to answer the MCQs and the questions that are present in the last part of the lecture, but you didn't put any questions in this lecture. But even so, it's a very nice presentation. Thank you so much.
Because it's a free webinar, okay? Free webinar is for discussion only, okay? In the
Okay,
course, we
okay.
have another strategy. Yes.
Okay, thank
Okay.
you.
I
Thank
have
you
one
so much.
question.
Of course,
Hello,
I'm listening. Yes,
can you hear me?
yes, yes. Dr. Jawahar, yes, I'm listening.
Yes, I have one question, that which type of PPH is more dangerous? Type 1 or type 2? Means primary or secondary PPH?
More serious?
Yes, more serious for patient.
I don't have, statistical analysis for that. It's not mentioned the guidelines that which is more serious or which is more life-threatening. But as regard that the primary postpartum hemorrhage is more common and it's the most common form of obstetric hemorrhage, it will be the most serious because the secondary postpartum hemorrhage is not a common situation. Okay.
Okay, one more question. If I
Sure.
receive patient in labor and after taking history, I know that she is grand multi and
Yes.
may she develops PPH, what should I do before delivery as a prophylactically to prevent the PPH?
We don't have except the active management. As I told you, if she's a grand multipara and you're suspecting that she's at high risk of having a primary postpartum hemorrhage, okay, or she had a history before that she got postpartum hemorrhage, so you should do an active management by giving a combination therapy, like giving a mixture between the syntocinon and ergometrin. Also, you can add tranexamic acid. And also make sure that you have like carpetocin and carpoprost, okay, in place, available in place. So in case she developed, you might give her, those medications. But such situations, you can give carpetocin if the patient is delivering by cesarean section, not vaginally. You can give carpetocin as a prophylaxis. Okay, but if not, then give a combination by symptometrin or which is a syntocinon and ergometrin, and also give a prophylactic tranexamic acid. Okay.
Okay, but when patient established and when should I go for the laboratory test or for HB level? After how many hours?
No, it's not about time. Okay, it's about the condition, the clinical condition of the patient. Now, like for example, now the patient is having established bleeding, so immediately you start the management. Okay, so you will resuscitate the patient, like make sure that she had an IV access, give her oxygen, give her the fluids until the blood is available, start transfusion of the blood, okay? And at the same time, you are doing a massage, you are giving the ecobolics, okay? This can take, 15 to 30 minutes. And if you, like you mentioned in the guideline, if you like give all the agents, and even after 30 minutes of the agents, of the pharmacological agents, especially the carpoprost, if given carpoprost, okay, there is no response, then you have to consider transferring the patient now to the theater for operating theater for a surgical intervention. Then you have to start giving putting the intrauterine balloon tamponade as a first resort for you. If not, responsive to the tamponade test or not responding to the tamponade, I mean. So you have to consider laparotomy and doing more surgical intervention. So it depends on the clinical symptoms and signs and the amount of bleeding, not about the time, okay? Because there might be
Okay.
minimal bleeding, but it's ongoing, okay? So this ongoing bleeding, yes, it's minimal in amount, but it's ongoing. So it can cause the patient to go in a shock, but in a longer time, or might be a severe bleeding, which can make the patient choked in a very short time. Okay, so this is depending on amount of bleeding and the clinical symptoms and signs.
Okay, what about the balloon tamponade? It is for the vaginal delivery or for the C-section also?
It's of course when it was invented, it was for the vaginal delivery, but it can be used in cesarean section, especially sometimes. Okay, and we have, by the way, we have practiced such cases in my hospital. Sometimes when you deliver the baby and the placenta, sometimes the placenta is low-lying placenta, okay, or if it's placenta previa, the uterine tone is very well, okay, and contracted, but the problem is in the placental bed itself. In the lower uterine segment, there is some, oozing, okay, and this oozing, it's not stopped by devascularization, and you want to, preserve the uterus with the patient. For example, she's only para 1 and she need more kids and so on. So sometimes we put this intrauterine, of course, we insert it vaginally and we inflate the balloon and we close the uterus, and then we notice the patient, and it can give good results in some patients. Okay.
Okay, thank you, doctor.
Welcome. Any more questions?
I have questions. In some questions in part 1 MR Etiology, there was a question about the normal blood loss in the delivery. It was the answer was from 500 to 1000 cc of blood. It's considered as a normal, as I remember. But now in this lecture, we considered it as a minor PPH. So when we see 500 to 1000, is it considered normal blood loss or minor BPH, or according to the situation of the patient?
No,
Sometimes you consider
I need the full question, please.
Okay.
Can you give
I
me all the
will
options?
say. Okay, I think it was about the normal blood loss and the delivery. It was
Yes,
just like
what were the options?
it was more than 500 and 1000 cc. More, the other options was more, 2000 or 3000 cc of blood. And one choice was 500
No,
to
average
1000.
the average blood loss in delivery is about 500 milliliter. Okay, that's the average. Okay, more than that, it's start to consider abnormal. But if you don't have this option in your exam, you have to select the best answer. Like, for example, it's if the minimal option you have is from 500 to 1000, okay, we are going to choose that. That's the best answer. Okay.
Okay.
But the average is usually 500 milliliters. Okay, thank you so much, everyone, for attending the webinar. Inshallah, on 19th of July, also, there will be another webinar by Dr. Desiree. She will talk about the first plot, something related to statistics. And of course, there will be more webinars to come before our course. So stay tuned and follow our page and our groups to see the upcoming events, inshallah. Thank you so much. See you. Bye-bye.